Welcome to another edition of Eye on the Issues. Joining me today is Dr. John Mansell, and we are going to be talking about Medicaid expansion, which is not going anywhere this session, Doc, and I know a lot of people are happy about that.
Well, every provider I know in Wyoming wants there to be improved access for patients. So I don't think happy is necessarily the right characterization, but we're grateful that there's a chance for us to find other alternatives. Let me put it that way.
Understood. And so let's talk about those other alternatives.
So the core problem with the Medicaid program is that it does not cover the actual cost of the care. And that's a problem for hospitals and providers alike, whether it's physical therapists, pharmacists, physicians, nurse practitioners. It doesn't cover the actual cost of renting office space, paying for your building, paying for your malpractice, paying for your staff, the new 12-year-old requirements for electronic medical records. And none of those are actually covered by the program. And so as a result, if we're promising people in the United States or any individual state that we have a plan to give them access to health care, promising them something that's a system that's based on not actually covering the cost isn't a very honest plan, right? Because it's not a sustainable plan. Eventually businesses who try to provide health care coverage or just health care, not coverage, they go out of business. And that's why we've had hospitals around the United States go out of business, because when they have a disproportionate amount of Medicare and Medicaid patients, because Medicare only covers about 80 cents on the cost dollar for a hospital, and the number is lower for Medicaid in most states, and it's lower for non-hospital providers. Obviously, if they lose 20 cents on the dollar for every patient they see, that's not an activity you can make up in volume. There's not an economy of scale where you lose on every interaction. And that's no fault of the patients whatsoever. Certainly no provider wants to blame the patients. It's just a recognition that the system isn't a functional system. Go ahead, Mike.
I was just going to say, is there anything to be learned from other states that have tried this?
Well, a great lesson from today in Ohio, 928 nursing homes are suing Ohio Medicaid because they feel like they were shorted $268 million. And next year, they're anticipating that number is going to be over $700 million. And that's just another data point, for those people who say, oh, the Medicaid expansion opponents are using old data. No, that's today's data. That story broke today. And the Band-Aid for hospitals, which I think if you have a Band-Aid program to help hospitals that see too many Medicaid patients, that's a tacit admission that the program has a problem, right? And so the Band-Aid is called, we call it the DISH program for short. It's the disproportionate fraction where hospitals who see so many Medicaid patients, they're even more financially stressed. There's a pot of money to help those hospitals out. Well, there's two bits of irony to that. One is it only helps 1 in 33 hospitals out that are actually stressed by taking Medicaid patients. The top 3% or the bottom 3%, depending on how you want to look at it, those hospitals are the ones that have a chance to get some funds to offset their losses. But they've been trying to cut $8 billion from that program since 2020, and everyone's fighting it tooth and nail because it's the only thing that's keeping some of those hospitals open. And even the American Hospital Association's Vice President for Policy Research, Ben Finder, had a public statement on that to both CMS and to Congress that this is going to worsen the ability to keep hospitals open. So that begs the question, how functional is the Medicaid program if it's still letting hospitals go under? It may improve the access to the patient until there is no access. And that's why we see mass migration of patients from let's say the Northeastern Corridor, New York, Pennsylvania, New Jersey, who actually commute to Wisconsin to get their health care on a Medicaid program because the Medicaid program saturated the hospitals in those states, and those hospitals couldn't tool up to expand to meet the service demands because Medicaid doesn't pay enough to them to actually be able to service those people, right? Again, absolutely no fault of the patients. It's just, it's a fault of the program. And then the other problem for states is they really don't set the fundamental rules for Medicaid. And as a result, they may have designed a budget that they find is sustainable. And then the federal government and CMS, they changed the rules for Medicaid. And now they have another line item or 20 that they hadn't factored in and they can't afford. Great example of that is from last week when the Biden administration announced that, well, you know, we can use Medicaid dollars for homelessness. I don't know any state of the 50 states who had a plan or anticipated that we're going to use the Medicaid program to help with homelessness. And that obviously, that's not a zero line item as far as cost. That would add a significant amount of cost to any state's budget. And the legislators are not able to plan for that sort of capricious behavior on the people who are in charge of that program.
And so this Medicaid expansion not going anywhere this session, did that surprise you or did not surprise you at all?
I'll believe it when the session gavels out and no one's tried it. Okay, let me first say that. And I don't necessarily, I'm not criticizing the legislators who are proponents of it. I think that their heart's in the right place. I really do. I don't want any legislator to think that I'm criticizing their good intent to try to improve access for Wyoming citizens. And again, because I don't want to be taken out of context, no provider I know wants to limit access to any patient in Wyoming. Okay, that's extremely important if you're someone who opposes Medicaid expansion and you're a provider. Having said that, though, they do it based on the misunderstanding that Medicaid actually covers the cost of the care. And in addition to being a self-employed physician, I also sit on a hospital board. And I can tell you that as hospital board members across the state, you know, we struggle with continuing to provide care with the under reimbursement that Medicare and Medicaid give us. You know, Medicare is supported theoretically by a tax program. It's a payroll tax, right? Medicare taxes. And so people who are on Medicare have spent their lives contributing to supposedly a fund to help take care of them when they get over 65. And so Medicare is a program that certainly no one would ever contest the eligibility of someone who spent their life paying for it. Medicaid, on the other hand, is not. And Medicaid also, for probably over 40 years now, has also been applied to the Social Security Income Disability Program, which also a noble program. But we exhausted that program and it went bankrupt 8 years ago because we spread that program too thin. And now we're over 13 million people in the SSID program, which has to claw that revenue out of the Medicare program. So over the last few years, we keep going, oh my gosh, Medicare is going to run out of money in 2042, then it was 2034. Now we're looking at 2028. You know, we're depleting that program. And when we do deplete the program, all the people that we have led to come to expect actual support and care from Medicare are going to be sort of left high and dry potentially. And that is where we sometimes conflate coverage and care. You know, coverage is a little golden ticket that says you're going to get health care, and that's great. But if there's no one left to provide the care, it's just coverage. It's not actually care. And the other thing that is pretty scary is that now that we've got, I know people will contest the number. Is it 8 million? Is it 10 million? Is it 20 million or more people who've now come into the country across the southern border? There will be an effort to put those people on Medicaid. That's already been openly discussed. And if we were to evenly distribute those people across the 50 states, Wyoming would get around 400,000 new people who needed Medicaid. but there's only 570,000 of us in the state. We're going to, we already have 76,000 people in Wyoming on Medicaid. So now for just about every person who lives in the state, we're going to have a person paying for someone else's health care. That's a difficult equation to come up with, especially since a lot of these other people are also paying income tax, sales tax, property tax. And now we expect our Wyoming citizens to pay for their care. I don't see that as politically saleable and certainly not fiscally sustainable. Again, no fault of the people who are looking for the coverage, but it's just an indication that the program is poorly crafted in its aspirations. Other ways to save costs, which you'd asked me at the beginning of this discussion, would be one would be if we want to save the hospitals, which are vital parts of every community. If you see a hospital disappear from a community, hospitals are usually the number one or number two employer in the community. It's usually neck and neck with the school system, right? Is just to have the state have its own direct aid program for the hospitals. And with that, the state can both sunset the program if they go, oh my gosh, this was too aspirational. Well, let's make it a 2-year program so we don't kill ourselves, with an obligation we didn't understand. And so having a direct aid to the hospitals would involve only maybe having 6 or 10 employees in Cheyenne to execute the program. It'd probably cost between $60 or $100 million, which sounds terrible until you put, 100,000 new Medicaid recipients and 2,000 new Department of Health workers to support and execute that program. So tiny by comparison. And I don't think we need to worry about someone moving another 27 hospitals into Wyoming to take advantage of our program. If anything, we would only say the program applies to currently existing hospitals in Wyoming that take Medicare and Medicaid patients. So I think it's politically defensible, a very efficient way to spend money, and it would help us preserve some very vital infrastructure in the 27 communities that have hospitals. Or the other program that actually would cost the state of Wyoming nothing, absolutely nothing, would be to introduce price signaling back into healthcare. And what I mean by that is, when a facility or a provider signs into a network with an insurance company, sort of the deal by going into a network with an insurance company is you will pay me faster and I'll accept a discount because you're going to say, yeah, I'm a credentialed, accepted member of your panel of providers for the patients covered by your insurance program. And so you tend to get paid faster. There tends to be less paperwork. And it also, if you're a provider trying to attract patients, it's a great way to say, hey, I'm in your network, and we provide a better price, so your copay is less, and and so we are a better provider. Well, here's one sort of hidden secret about network contracts. Let's say you have a deductible of $5,000 or $10,000, okay, and you go see a provider, and you need to get a service from them. Under the contract to you, the person who bought the insurance, and under the contract to the provider who agreed to be in the network, you're both required to pay and charge the network price inside the deductible. Okay? So if you think about insurance contracting as a triangle, the insurance company's at the top of the triangle, and one leg is the patient, and the other leg is the provider. You can understand those two upper legs of the triangle between the insurance company and the provider and the patient. Okay, those are a contractual relationship. But what they've done is they fixed the bottom of the triangle to where they're forcing you to charge a price that, from the patient's perspective, is still expensive, right? And they're not allowing you to haggle on it, right? So if you forbade insurance companies from fixing prices within the deductible, then that would mean that a patient could go out and go say, I need a total knee. Let me go see who's got the best 5 prices for total knees. And they can go out and haggle for it, right? And the beauty of that is if you ask an insurance company executive privately, they go, oh, no, we'd love to have that. Because theoretically, that means every patient becomes an empowered agent of the insurance company to find better value, and they're less likely to breach their deductible, right?
Sure.
So that means I would have to compete on price point, just like gas stations and clothing stores and everywhere else in every other industry sector where pricing is a significant component of the customer's decision about who they're going to use. Now, the one pernicious theory in all of this is that insurance companies are not that interested in it because they love to have high prices because it scares people into buying healthcare insurance. I'm not sure I buy into that theory. But you can see how if we were able to put that price signaling back in, one, it costs the state of Wyoming nothing. And the only people who are unhappy are people like me who sell healthcare services. Well, too bad. That's just tough. We got to grow up and become like other businesses that have to compete on all fronts, for all attributes of our services. And I think that would be very exciting, even if the law was only in effect for 2 or 3 years. I believe what you would find is people would get a better value and prices would actually soften up across the state of Wyoming. We might even see people come in from other states, or we might become the model law for other states where they go, oh, look what Wyoming did. Well, that was smart. And we would see healthcare prices actually soften and drop because we're having to compete like real people.
So I know you got to run because we're running out of time. Real quickly, have you run this price signaling by any lawmakers? Has anybody bid on it and said, I like that idea?
I have, but it's not the easiest soundbite to pitch. The elevator pitch is maybe if you're going up 90 floors, it's not a 5-floor pitch,
Right.
But yes, it's been discussed, and I'm hoping that engaging people like yourself, Mike, and maybe getting the concept out there, maybe even with some of the other digital media in the state, we might be able to get the concept to where it's more accessible to legislators to see that it's a cost-free alternative to try.
Yeah, it's a great idea. Fantastic. Doc, I know you got to run. I really appreciate your time. If people want to find out more about what's going on around Wyoming, wyliberty, wyliberty.org. Be sure to sign up for our newsletter. Thanks, Doc.
Thank you, Mike.
Take care.